So Dr. Prodip Kumar Doley is Professor and Head, Guwahati Medical College and Hospital, recipient of many awards, contributed many chapters, especially in the update in APISM, has many publications to its credit. Over to Dr. Doley.
Okay. Good morning to all. Respected chairpersons and distinguished guests. At the very outset, I would like to thank the organizer for giving me this chance to be a part of this conference. So I've been assigned to speak on managing fluid and sodium management in CKD as a part of nutritional management. So as you all know that CKD is characterized by progressive decline in the GFR and also the progressive decline in the renal excretory function that leads to disturbance in the sodium and water.
There are a lot of echo in the background of what he's talking.
So disorders of these two components will lead to the disorders of volume regulation. So we all know that these two are the main contributors for cardiovascular morbidity and mortality in CKD population. So to get the optimal outcome in CKD, so you need to manage these two components because two things are very and a central position in the management of CKD. So this requires a comprehensive approach in integrating the dietary sodium restrictions, so individualized fluid management and the pharmacological therapy, and most importantly, you need to monitor the patient of CKD regarding volume status and the sodium content. So why this topic is matter to us? So CKD, already I mentioned that it is associated with sodium retention, it is impaired free water clearance, and also there are multiple endocrine dysfunctions are also associated with CKD. So all these factors will lead to the volume expansion, and this will amplify the blood pressure management. It will have an impact on the left ventricular restraint pattern. It also increase the progression of the kidney disease. So nutritional management is just not a adjunct therapy. It is a core component of the CKD management therapy. So because these two will directly shape the symptoms burden, and it also influences the medication effectiveness and also the hospitalization risks. So a small daily amount of sodium excess can lead to clinically excess fluid overload, and especially when GFR is falling down or when the patient is getting an intermittent sort of dialysis. So what will be the clinical consequences if you don't address this in a proper way? So there will be poor BP control despite the multiple agents. So a patient will have a peripheral edema, and if it is severe, then patient may go into a frank pulmonary edema. In a subset of dialysis patient, it may increase the intradietary weight gain also. It also reduces the antiproteinic effect of ARBs and the diuretics effects also. It can lead to a diuretic resistance. Then overall, if you see finally this will increase the cardiovascular mortality and the morbidity. So what happens in a sodium homeostasis in CKD patient? So this is the normal physiology. So what happens in this one? So as the reduced nephron number is there, so the single nephron burden will be increased. The single nephron will try to compensate for whatever loss of nephron is there, but this compensation is lost. So this ultimately leads to your activation of the RAS system and activation of the sympathetic nervous system, which will promote the distal sodium reabsorption. And even the salt sensitivity in CKD patient is also increased. The pressure and natriuresis curve will shift to the right side, and even the high BP will require to normalize the normal sodium intake as like in a normal individual. So there is a new emerging concept of sodium is there. So spooky sodium phenomenon. What is this? So there is a third compartment sodium accumulation is there. Apart from the ECF and ICF, so there is a third tissue sequestration of sodium is there. This is a new upcoming topic. So this is the direct sodium attachment to the tissue, where the tissues are negatively charged glycosaminoglycans are there. So they will directly attach to that protein, and they will attach there without retaining the water. So why this is important? Because these act as a pro-inflammatory drivers, so which is mediated by the macrophage that will increase the systemic vascular resistance or systemic inflammations. So this can be nowadays with a modern technique can be very effectively identified by new technologies like sodium MRI. So it will pave the way for individualized management of these targets. So what is the water disarmament? What is the pathophysiology of fluid dysregulation in CKD? So it is again same, like as the nephron number is decreased, so the water clearance is also less. They will try to compensate for the loss. This one, even those who are surviving nephrons are there, so this compensation is even that capacity is also weak because they cannot challenge the fluid overload condition. So ultimately, this will lead to extravascular fluid overload without dramatic symptoms in the early stage. So this factor may be again compounded by many factors like the presence of heart failure, the presence of diabetes, and hypoalbuminemia. So these are the systemic toxicities of sodium and the fluid. So this will have a direct impact on the cardiac remodeling. They can induce the oxidative stress, and they can help in the atherosclerosis, and they act as a pro-inflammatory cytokines. So how do we manage this? So these two components. So core clinical objectives will be, you need to construct, you need to understand what is the pathophysiology of altered sodium and the water balance. So you need to differentiate different compartmental distribution of the sodium. Not only the ICF and ECF should be also tissue compartment. You need to evaluate with the help of the modern diagnostic tool. So what is the what is the extent of fluid overload in this particular patient, and finally you need to integrate with the KDIGO 24 guidelines to manage this volume and the sodium by SGLT2 and the MRSAs. So this is the algorithm for stepwise volume management. So first step will be always you need to move beyond the normal pitting edema. So you have to take the help of bioimpedance spectrometry. You need to do the IBC diameter, and you need to do the lung ultrasound to assess the actual volume status. The fundamental, mandatory fundamental step is that you need to restrict the sodium intake. And you need to escalate sometime. If you need to initiate a dialysis, okay, diuretics. If diuretics is not effective, you need to do sometime a sequential blockage of the nephron as well, and you need to give the adjunct therapy, adjunct modulative therapy like SGLT2 and S. So how do we monitor the volume status in CKD patient? Especially this is for, usually you do in the ICU setting, but even in the clinical bedside also you should do. So clinically you should see what is the assessment, what is the, you need to take the history in detail. So what is the type of water intake, what is the type of sodium intake, so what is the urine output of the patient, what is the BP, whether it is increasing or decreasing, so what is the body weight, that is also very, very important. And a subset of patients who are getting dialysis, also you should assess how dialysis has been tolerating. And those patients who are not on dialysis, you need to monitor the RFT so that what is the trend of deteriorating renal functions. And you can take the help of how, you can take the help of chest X-ray, you can do the IBC diameter, ultrasound, you can do the focus study, you can do the VEXAS study also. There are certain biomarkers there which also may increase in the CKD patient, but falsely they are elevated because normally these biomarkers are secreted by the kidneys, but because of there is a loss of kidney function, so this will retain in the body. And you should not go for a single factor, single value. So you should see what is the trend of this biomarker, whether it is up and down. And you can do the functional assessment like 23 sodium MRI to identify what is the tissue sodium distributions. And you can also take the help from remote monitoring like eye health trackers. So you can get the data from that, and you can individualize based on the parameters. So this is the VEXAS study. So this is actually whether there is as a part of focus, we do the VEXAS scan because this will give you the actual volume overload is there or not. Or not only we have to see the IBC diameter. So IBC diameter may be sometimes dilated because of many other factors. So you have to move beyond the IBC diameter. So you have to do the hepatic vein Doppler study, you have to do the portal vein Doppler study, and you need to do renal Doppler study to assess the actual volume overload status. And depending on what is the grade of the severity of the volume status, so by this you will know and how aggressively you should manage. So this will help you how to manage the volume status aggressively. So what is the principle of fluid restriction? This is a fluid restriction is not automatic, so universal for each and every patient of CKD. It will depend upon what is the urine output of the patient, whether the patient is symptomatic or not, whether any evidence of heart failure is there or not, any associated electrolyte disambulance is there or not. So everything will depend upon the clinical patient's profile. So where there is no clinical significant volume overload is there, so you do not see only the fluid part, you should see also the sodium part. So typical approach will depend upon the character of the patient. So it is a non-dialysis CKD patient and edema and oliguria, or it is what type of dialysis they are getting. It is a peritoneal dialysis or hemodialysis. Based on that, you have to adjust according to. This is the overall fluid management chart in the CKD patient. So fluid managed intake should be equal to the previous 24 hours urine output plus inchable loss of 500 ml. And if patient is oliguric, then you should be more stricter. If patient is non-oliguric, then you should be liberal and you should be individualized the patient. So in a dialysis patient, patient, so we should see how much of expected inter-relative weight gain you are expecting, and what is the baseline urine output, and the patient should know what is the concept of dry weight. So if the physicians only know what is the concept of dry weight, so it is not important, because patients should understand what is the importance of dry weight. And if patient is on peritoneal dialysis, so it should be the ultrafiltration plus urine output should be equal to the fluid intake. So there are certain clinical practical tips are there. So whenever they take the fluids, so they take the fluid in the measured bottle or marking bottles and use the small cup instead of B1, and the sips of ice can be taken in spite of the water, and all the salt content, high salt content food should be avoided. And this was one study which shows the restriction of the fluid, which retard the progression of CKD and slash the mortality in advanced CKD. So this study was done for 100 patients who were enrolled in this study. Those who were euvolemic in normally on physical examination were euvolemic, but they have been subjected for BCM study, and based on the BCM study, they have been grouped into two part arm. One is the normovolemic and hypervolemic arm. The trigger, interventional trigger was the BP. So if BP is more than 130/80, and the normovolemic arm, they initiate the dialysis to maintain the strict normovolemia, and if they are hypervolemic state, they start the vasodilators, and they add on dialysis depending on the patient's requirement. Okay, diuretics based on the patient requirement. At the end of the 1 year, what they found was that there was significant improvement in the renal function. There was a proteinuria decrease was also there, and significant improvement in the BP was seen in the low normovolemic patients. They have also looked into the critical endpoints like requirement progression to the dialysis and all-cause mortality. Also, it is seen that the all-cause mortality and progression to CKD was significantly lower in the patient with normovolemic arm. So how to manage with CKD, sodium in CKD? Sodium
so Dr. Prodip, we'll have to summarize because
okay.
1 or 2 minutes we'll give for question answers.
So yes, sodium is a driver, we all know it. So dietary assessment of sodium is very, very important. The patient should know, even the dietitian should tell them how to calculate the sodium content, and these are some of the foodstuffs. Those contains very high degree of sodium, especially processed and ultra-processed food. And this is a sodium management, so sodium restriction should be less than 2 grams per kg per day. In a dialysis patient, this will help in reducing the BP, the decrease in the edema, and proteinuria will be also decreased, and drug efficiency also will increase. So practical tips that use less salt in cooking. So you should read the food level, sodium levels in the food, and you should choose the fresh food instead of. And this was the one trial, which is to see the efficacy of dietary sodium restriction and progression of the CKD. This is a double-blind placebo-controlled trial and randomized trial. It was published in 2018 probably, and what they have grouped into two groups. They have grouped into two. So one is the low sodium diet, one was the in high sodium diet. So it is seen that hemodynamic parameters, the ambulatory blood pressure and the body fluid composition is significantly better in patients those who are in the low sodium group. And they also seen, looked into the renal and hormonal and vascular component. It is also been seen that the renal outcome was almost 50% reduction in proteinuria and albumin in the low sodium group. So regarding the reading the food level, sodium level is also very, very important. The food preparation strategies that should advise, the dietitian should advise how to prepare their food. And there are myths and misconceptions are there and regarding sodium. So only water means what? Is it okay? No. Sodium is a major driver for thirst and fluid retention. The rock salt, sea salt, and pink salts are safer than the normal salt. No, until and unless they fall truly into this category. So they are rich in potassium especially. So if the food is homemade, then automatically it becomes a low salt diet. No, because even the pickled salt and mixes are also count. And the fluid restriction should be severe in all CKD patients. No, it should be individualized based on the urine output. So this is the KDIGO 24 guideline that dietary intervention. What should we do? So we should restrict the sodium intake to less than 2 grams per day. You should avoid as much as possible a potassium substitute for the low sodium, and you should stop taking hidden salt or hidden sodium containing food. The take-home message will be that fluid and the sodium management sits on the central position in the nutritional management of CKD. It is not a part of the adjunct therapy only. It should be a part of core component. And below 2 grams of salt restriction to be done. And the dietary counseling should be done by the dietitian. And sodium and water restriction will improve the BP as well as the often it also increase the effectiveness of medications. Fluid balance allowance depends on the urine output. It's a clinical context, not on the diagnosis alone. And long-term fluid success depends culturally and realistically how the behavioral changes have been made. Thank you. Thank you for your patience.
Thank you, Prodip, for covering this very vast topic. Both basically, salt itself is a topic by itself, and there should be a lot of discussion and symposium on salt itself. But here you try to cover up both salt and fluid. Just a few important points that most patients would require salt and fluid restriction. There are a few salt-losing nephropathies, and it's more important in children where this entity is a little more, and therefore salt and fluid restriction doesn't automatically go in that group of population. Otherwise, salt will never be out of fashion. As far as guidelines have come and gone, proteins have changed, phosphates have changed, potassium has changed, but salt continues to be the most important restrictive agent and is really value for money if you follow this salt restriction guideline. Fluid, again, we know is a difficult customer, and more so in dialysis patients. So thank you again, Prodip, for this talk. Please come and take your seat.